So what I'm going to do, I think we're going to have Dr. Furie join us remotely, if that's possible. And I have a bunch of, hello, Dr. Furie.
Possible.
Okay, there he is. Okay, so we have, unfortunately, limited time. We have 5 minutes for questions. Let's start with a question from the microphone here, Dr. Lavery.
Hydroxychloroquine inhibits autophagy. I'm trying to figure out how autophagy works for the improvement of lupus and the conditions, and especially autophagy for lupus nephritis. I thought that autophagy is what we need to keep disease to ameliorate lupus nephritis. Thank you.
Rich, do you have any ideas there?
No, I was going to let you answer that, Ken.
Let's move on.
I don't know. I honestly don't know your answer. Al, can you answer it?
I'm not going to answer that. Al, Kim, it's good to see both of you. This is more directed to Ken because it was in your topic, but yeah. Rich, you're always happy to pitch in. I've gotten 180 on proteinuria as a biomarker that I really want to follow. I think there's a lot of good data from Rich Furie, and also AMP, the clinical portion about people who are in clinical remission but still have histologically active disease, and these people don't do well long term unless you switch immunosuppression. Just comments on that.
So, what are you driving at? What's your question?
Well, I guess the question is, again, the Megan Mackey paper that you had referenced, you guys, with proteinuria being probably the best biomarker, and also with Maria Dellera's analysis of the Eurolupus data, right, with the 0.7 threshold. I think one of the issues is obviously, as Rich had mentioned, better and good, all of this is below good in my mind, right? Mm-hmm. And so even though we are promoting these biomarkers because it's just what we can measure, I think I'm a little bit more concerned about having people over-interpret the importance of such biomarker data.
Good question. Yeah, I get you. Yeah, so should we rely on these it would be ill-advised to rely on biomarkers when really we care about more functional aspects that we know are grounded in the pathology of the disease. I completely agree with you. I think, though, that it's an adjunct, right, to see how we're doing. It's easier to do, it's easy to do random urine protein creatinine ratios, but they're often flawed. It's easy to get urine proteomics, I guess. I think the more data you have, probably is better, but I think the bottom line is maybe the role for urinary biomarkers are not necessarily for outcome, but for diagnostic things. I think that is a huge thing, right? If you can do a urine test that shows what type of disease you're dealing with, membranous versus proliferative or a combination, you don't have to do a renal biopsy. And so I think that's where the excitement is, but I think that we may have some aspects of outcome that may be better defined. Like looking at, for example, a fibrotic pathway, right? That's something that we can't get at. Maybe that would help if we adopt the idea of using voclosporin first in conjunction with MMF and then switching over. Maybe that'll tell us when that time is right to make that change.
Rich, do you want to jump in on that?
Yeah, this has been a pet peeve of mine. I mean, proteinuria is a terrible endpoint, but it's the best one we have. Do a biopsy on someone who's had a proteinuric response, and when you see still a lot of histologic activity, it's an eye-opener. So I refer you to Anna Malvar's article about 6 or 7 years ago, where she did second biopsies, and 40% of the patients who had complete response, that is proteinuria less than 0.5, still had activity, NIH activity index of 3 or greater. So I just wonder about, we're all pushing ACE inhibitors and ARBs and now SGLT2 inhibitors so we can reduce proteinuria, but what's really happening in the kidney? So I agree with Ken, there's a need for biomarkers that reflect inflammation and damage accrual.
All right, so I need fast answers. Are doing hydroxychloroquine blood levels, is that standard of care yet or not?
It's standard of care for me, but I must say people in my group are not routinely sending those off. Company on the West Coast, Exogen, does a whole blood hydroxychloroquine assay, and turnaround is just a few days. And also, that's a real eye opener.
Yeah, I mean, I'm not doing them now. It's not easy for us to get at our institution. But it is an eye opener because there's data from many sites that have shown that what we're finding is patients aren't taking their plaquenil.
This is going to turn out to be an East-West Coast battle. I like this. If you do blood levels, when should you draw them? Does it matter?
For hydroxychloroquine, it doesn't matter.
Okay. You made a big point about damage, Rich, but how do we treat damage? Obviously, don't use prednisone, control blood pressure, control modifiable risk factors, but what should we be thinking about treating damage?
Well, it really depends whether the damage is from the medications that we're using. So yes, less may be better. But the other thing, especially for kidney disease, is, and Ken had it in his slides, antifibrotics. And I think that's one of the next frontiers, to introduce antifibrotics. So not an easy topic to study.
No, we heard from Mike Brenner about that yesterday, but yes, that seems to be on the horizon. Steve Lindsay and others asked the question about how do you choose and when do you choose between anifrolumab or belimumab? Ken, do you want to start with that one, and then Rich, give us your fast answer?
Well, I think that for me, from what we've seen in the clinical trials, anifrolumab looks like it's a great drug for skin and works faster. That's the most important aspect of those studies for me. I think the joints are a difficult situation. I mean, we don't really know how to measure outcome or clinical effects from drugs in development for arthritis, and so it's sort of a puzzle with both. I think that it seems to me that anifrolumab works a little bit quicker, so belimumab takes a while, so maybe anifrolumab beats belimumab in that aspect. Rich, what are your thoughts?
No, I agree. For skin, anifrolumab is a real standout and it works very quickly. I think rheumatologists are very good observers and they just have to try these medicines.
Yeah.
So in the last 2 months, there have been a few case reports of anifrolumab being used in DLE. Rich, would you endorse that? And then the other question I have is, or we've had is, how can you use these drugs, these newer drugs especially, in overlap disease and MCTD? So first, DLE, what do you do, Rich?
Well, patients who were enrolled in the anifrolumab studies were not characterized as to the type of skin disease that they had. But I certainly know from my own experience, it works in DLE. And the second question about overlap, I guess it really depends what manifestations are being targeted. But again, rheumatologists are good observers. Try it.
Okay. I think our last question is, how do you dose hydroxychloroquine in patients with CKD? Do you make adjustments or not? We heard that obviously it could affect the drug levels, but do you dose adjust for CKD? Rich?
Well, all right, I can go. So I'm a big believer in that we should, not just for lupus, but all rheumatic diseases, maybe all inflammatory diseases, treat by exposure. And since I can easily get hydroxychloroquine levels, I don't worry about the milligram per kilogram dose and so forth. I just send off a blood level. And we should probably be doing that for all of the drugs that we give, as long as we know what the target is, toxicity levels, and the information that's necessary.
Yeah, I agree with that. I do use a decreased dose in CKD. I do 200 milligrams. But I think that it's wise to check levels. That's a good use of levels.
All right, I want to thank our speakers for a wonderful session. Thanks, Rich.
All right.